Welcome to the September Learning Series with the Stanford Healthcare Design Challenge. We're so excited to have two amazing speakers today. As a reminder, what SHDC is all about, only 7% of any projects after a hackathon had any activity 6 months after. And so what we're trying to work on at SHDC is how can we bridge the gap between execution and ideation to implementation. This year, we have a global vision, which means we want to get students from anywhere around the world to work on ideas on global health. Our design challenge is aimed to have a global reach and impact. And for our key dates, so as you know, our prompt has just been released on September 1st. From September 1st to 19th, we have our open learning series where we have a bunch of awesome speakers talking about their background relating to global health, technology, and venture capital. On September 22nd, we have our applications due. And then October 6th to 17th, we have our actual competition with our demo day ending on September or October 17th. So please apply if you're interested in global health, innovating in the space, and meeting awesome people and developing your leadership skills. Here is our Gmail on the bottom if you have any questions, and please fill out our interest form also to stay updated. So during our 2 weeks of our competition, our goals are threefold. Teach our participants about value proposition, data strategy, storytelling, all accumulating in our demo day when we have 5-minute pitches to our judges. And without further ado, I will stop sharing my screen and pass it off to the both of you.
Okay, it is my honor to introduce Dr. Mulugeta Tenna, an Ethiopian medical doctor and humanitarian worker with nearly 2 decades of experience in clinical care, refugee health, and academia. From 2008 to 2024, he worked with Africa Humanitarian Action, serving as medical coordinator at Kiziba Refugee Camp, and later as senior health coordinator overseeing camp-based and urban refugee health program, where he led efforts to strengthen access to care for displaced populations. He has also served as assistant professor of surgery at Jimma and Hawassa universities in Ethiopia and currently holds the position of assistant professor of surgery at the University of Global Health Equity in Rwanda, within the Center for Equity of Global Surgery. His career reflects a deep commitment to health equity and to ensuring that refugees and vulnerable communities are not left behind. To introduce our second panelist, we have Dr. Dieudonne Nsengimana, who was a Rwandan medical doctor with 7 years of progressive experience spanning clinical practice, peacekeeping, and humanitarian health. He began his career as a physician in a district hospital in Rwanda before serving for 18 months in South Sudan as a regimental medical officer with the United Nations mission in South Sudan. Following this, he joined Africa Humanitarian Action as a medical coordinator based in a refugee camp in Rwanda, where he focused on strengthening access to quality healthcare for displaced populations. Since 2023, he has been serving as the Health and Nutrition Program Manager for Save the Children International in Rwanda, overseeing the national health and nutrition portfolio and leading efforts to improve healthcare delivery and nutrition outcomes for vulnerable communities. So now I hand it off to you guys. Thank you.
Thank you. Thank you very much for the kind introduction, both of you, Richa and Zainab. So I'm going to go through the presentation. I've prepared some slides. So then maybe we'll move to the Q&A session. So this presentation is jointly prepared by me and Dr. Dieudonne. So let me upload the presentation. You can see it now, yeah? Great. So, as I said, I will go through briefly about our experience about refugee health care in Rwanda. So I've spent like almost 16 years in the refugee health projects from 2008 to 2024. Then recently I moved to UGHE, which is a university with main focus on global health and health equity. So my presentation outline looks like this one. I will first discuss about Rwanda's health system because it affects also the refugee health. So I will briefly talk about Rwanda health system. Then about the refugee context, about the demographics, the current demographics in Rwanda, about the refugees and their locations, and how is the healthcare delivery system for refugees in Rwanda, and the funding system, and the refugee integration into the different national systems, and what are the opportunities and enabling environments that facilitate access to health for refugees. Then finally, about challenges and few recommendations. So as you see here, the Rwanda health system normally starts from the community. Usually this is handled by community health workers who are elected by the community. These are very respected people. So they are trained and provide basic curative services focusing on malaria, pneumonia, and diarrhea. But their main focus is on promotion and prevention of diseases. Then after that, patients can be seen by primary health care facility like health center or health post. Then depending on the case, they can be referred to the first level or district hospital, then to the higher level of healthcare like secondary and tertiary. And there will be also a counter referral from the higher level to the lower level. So Rwanda has a decentralized model of healthcare focusing on primary healthcare, and their main focus is on maternal child infectious diseases and recently also on non-communicable diseases, including cancer and mental health. When you see the infrastructure, Rwanda has achieved to have at least one district hospital per the district and 17 health centers per the district and 43 health posts, so that they have enough access to healthcare system. So the health facilities are more closer to the community. About the human resource, currently we are a bit behind. There's one skilled health professional per 1,000 population, while the WHO recommends about 4. So to reverse this, Rwanda has initiated a 4x4 health reform, where they are going to quadruple the trained professionals in the coming 4 years. What about financing? Financing is a challenge, but despite that, more than 90% of the population, Rwandan population, are covered by community-based, sorry for the abbreviation, community-based health insurance scheme. And to improve the quality of the services and also to motivate the staff, they have this what called performance-based financing. So in quarterly basis, they would do the evaluation, they assess the quality of the service, and the staff are motivated by getting this fund. And they have also a nationwide health management information system that helps them for monitoring, evaluation, and decision-making. So I move quickly to the refugee context. In Rwanda currently, Rwanda hosts around 136,000 refugees. And these refugees mainly are from Democratic Republic of Congo, contributing 61%. And Burundians, they contribute about 38%. So other nationalities, they are almost less than 1%. And most of the refugees are located in the camp-based settings. So that's why urban refugees only contribute 9% of the total refugee population. These are mainly living in the capital city, Kigali, and also other cities. And women and children, they contribute almost 75% of the population. So you can imagine there are households which are headed by only women and also maybe children and accompanied minors. And on average, there are like around 4 individuals per family. But when you see the household, like their housing structure, it's very small compared to the family size. So it has also an impact on the health of the refugees. And there are around 5 camps and other transit centers. And the largest camp is the newest one, which is Mahama. Almost 50% of the populations are living there. So this, I don't know if you can see it very well, but yeah, this is the map showing the locations of the camps and also the people living in the cities. So as you see, like refugees are living almost all over the country. So you can see the west, the south, the east, the north, and also in the center. How is the healthcare delivery system for refugees? Because we follow the national system, still we have the community health service led by community health workers and followed by primary health care, which are mainly located in the refugee camps, and cases which are not handled at the primary health care or at the health center level, they are referred to the secondary care and tertiary care hospitals, mainly in the capital. So we have a wide range of health services involving promotion, like health education, breastfeeding, preventative, like immunization services, and basic security services can be provided in the campus health facilities. So this shows the top 5 causes of morbidity. This is almost every month you see upper respiratory tract infections or acute respiratory tract infections predominates, and other also infectious diseases are there. Nevertheless, NCDs, cancers also are becoming now common. That's why we have to focus not only on infectious disease, but also on non-communicable diseases. And other chronic infectious diseases like HIV, the people are getting antiretroviral treatment, which are available in the camps for camp-based refugees. And also they can get also from the government public health facilities for those living in the capital city or maybe other cities. And we have also other kind of HIV services like preventive services. Sorry again for the abbreviation. PMHT is prevention of maternal to child transmission. VCT is voluntary counseling and testing, and also support for the discordant couple. And TB and hepatitis management are also there integrated in the HIV services. Just for your information, these all services, HIV, TB, hepatitis, and also malaria are also integrated into the national health system because we are getting the drugs, the testing kits from the government. So refugees healthcare is not isolated healthcare, it is integrated into the national health system. The other focus is on the maternal health. We have antenatal care for pregnant women and deliveries, postnatal care after delivery, and also we have family planning for the modern contraceptives. And if there are some complicated cases, they can be also referred. But one of the camps, which called Mahama, the second, can also do cesarean section in the camp. This is because it's a medicalized health center. But other health centers, normally they refer to the district hospital for cesarean sections. I've already mentioned about NCDs, mainly hypertension, diabetes, and asthma management. They are available in the camps. And also the mental health services and psychosocial support services are available. As you know, refugees are highly affected by the mental health situation because of their situation while they are in the countries of origin, during their flights, and also in the country of asylum. So there's a comprehensive management of mental health diseases in the camps. The other main service we provide is nutrition. Nutrition we provide as a prevention or a supplementary feeding or a therapeutic feeding. When you say like promotion, for example, for pregnant women, lactating women, and for people with TB and HIV, they get extra food from WFP. And children who are affected also by malnutrition, either by moderate acute malnutrition, we call it MAM. Also, they get support. And also those severely affected children with severe acute malnutrition, like kwashiorkor and marasmus, also they get the services. So I move to the funding system. Who are the funders for the refugee health program? Our main funder is UNHCR. This is United Nations High Commissioner for Refugees, and WFP, World Food Program, usually provide in-cash assistance for refugees who are not able to feed themselves. So previously, WFP used to give for all refugees, but nowadays they don't provide for all. They provide only for those who are vulnerable. And other international donors, UNFPA, and so on. And there are some international and national NGOs also that participate as a project partners. And as I've mentioned also, the government is a key partner, providing so many commodities for free. So what's going on about refugee integration into the national systems? In September 2016, so there was a New York declaration at the summit of the head of the state. The government of Rwanda committed, okay, to integrate refugees in different sectors. One of it is on the education sector. So nowadays, refugees, they go to the government schools, either in primary, pre-primary, and secondary, and few also they have chance to go to the universities. And healthcare integration, it is there, as I mentioned, like TB, HIV, malaria, and other family planning programs. But in addition to that, refugees living in urban areas, because there is no allocated health facility to provide the health services, they get community-based health insurance, so they can go to any government health facility if they have that insurance scheme. So the premium is covered by UNHCR, and the service is provided by public health facilities. Other integrations is in the integration into the financial services and economic and livelihood integrations. The World Bank, there is a World Bank project. It's called Jambere 2. This is the second phase, investing around 66.7 million on livelihoods. So this project helps to expand the education, the health, water and sanitation system, and the roads, okay, to the refugee camps, and also some of the markets, bringing the markets closer to the refugee camps, so that this makes refugees self-reliant and they are able to have more access to healthcare services. So what are the opportunities? As already mentioned, government policies. In Rwanda, the refugees, they have freedom of movement. They can go anywhere to work. They have access to ID cards so that they can have also access to the financial services, and they have also the right to work as a policy. And also they have been integrated into the different national systems I've already mentioned. And there is also a facilitator, like a kind of policy internationally called Global Compact on Refugees and Comprehensive Refugee Response Framework. Maybe I don't want to go into deep about these ones, but these are frameworks that facilitate refugees to be integrated with the national. So funders, they give the money to the government so that this money will be used to help both refugees and the host communities at the same time. So this is like sharing responsibilities by all actors. So these are the challenges facing refugee health program. As mentioned, these are health related to the clinical services, and mainly it is the social determinants of health. As you know, like almost 80% of the health is affected by social determinants, but the clinical service is only contributing only 20%. But our main focus used to be like on this, like improving the infrastructure, maybe the commodities, but normally we don't focus on the higher level or the systematic determinants of health, mentioned like poverty, limited education. That's why this fund from the World Bank is mainly focusing to alleviate the refugees from poverty and giving them access to education and improving the like water and sanitation and hygiene conditions and the housing conditions. So if you focus on the social determinant of health, it will have a bigger and sustainable impact for the refugee health. So at last, my recommendation is to continue strengthening the refugee integration into the Rwanda health system, education, livelihood, and financial structures. And maybe as youth or young person, maybe to devise innovative way of healthcare options like digital health, moving into the digital health. So with that, I think I conclude my presentation. Maybe if Dr. Dieudonne wants to say something. So thank you very much. Over to you.
Yeah, thank you very much, Dr. Mulugeta. I think the presentation was a very explanatory, and you mentioned most of the things. Uh, I think maybe if there is time allocated for maybe questions, that is where we'll come. Otherwise, yeah, thank you for the good presentation.
Thank you so much. This was super informative, especially as someone who doesn't have a lot of experience in specifically the Rwandan refugee landscape. This was really helpful to understand the background. I know you mentioned several social determinants of health challenges and also clinical challenges facing the refugee population. If you had to summarize in like one or two words, what do you think are the most pressing problems facing the refugee population? And what do you think are the most important stakeholders people should consider when designing solutions for these people?
Yeah, okay, I think I can go first. Yeah, yeah, thank you. As Dr. Mulugeta said, that social determinant of health, of course, is the key because there is no way you can tackle health challenges without looking deep to social determinant of health. Uh, for refugee in Rwanda, as Dr. Mulugeta said on the background, you can see that they are even old camp more than 25 years. And most of them, they are concentrated in a very small land area, if I can say. And they have no land, they have no job. For this, of course, Rwanda government has tried the best to make sure that the refugees are integrated, especially in the financial system. But when you look on how refugees are living, especially for me, I can focus on access to healthcare. For the refugee, because they rely on donor funding and they don't have money, they don't have job to access, because, for us, of course, to provide healthcare, we focus only on life saving. But for elective cases, they wait long to be approved and they cannot afford themselves. So I think the best way to tackle social determinant of health, of course, is to promote refugee resilience, like improving livelihood, as Rwanda has started. Although, of course, there is small number of refugees who have started to do those job for livelihood, but to continue increasing the livelihood activity in refugee camp will strengthen the capacity and the self-resilience for refugee to be able to afford the healthcare and other services. Uh, and another thing I can say is also to to integrate, to fully integrate. I know that Rwanda has committed to integrate refugee in community-based health insurance. This is to, of course, to reduce the catastrophic spending because I know that, especially for refugee in urban, they pay a fund for healthcare themselves, uh, except some few of them. But I know that also there are some who can't access healthcare due to this issue that they are not, they don't have insurance, they are not enrolled in community-based insurance. So this commitment of enrolling refugee in community-based health insurance will also increase access to healthcare for refugee, not only for urban refugee, but also to refugee based in the camp. So that is what I can add. Dr. Mulugeta, you can also add over to you. Thank you.
Yeah, thank you, Dr. Dieudonne. You have already explained like the strategies, like the main focus of strategies that will improve the health access to refugees. Even my idea is like, most of the refugees are dependent on the external aid. And you see also the financial crisis globally, from the US, like the donation has declined. So to depend on those global like funding nowadays, it's not working. So there should be like humanitarian workers and humanitarian agencies and developmental agencies have to work together so that most of the refugees are like become like self-reliant. How they can be self-reliant? One is education, starting from maybe primary education, secondary education, and university level. The other is also to involve them on the vocational training for those who are not able to join the formal education. And the other is also to start like or to strengthen the livelihood activities which are already started. So if a refugee becomes self-reliant, the access to health will be much easier. I think these are the basic like solutions. Then stakeholders, as you said, like international organizations, okay, they have to be involved. And the government of Rwanda is taking the initiative, but the responsibility should be shared by also international organizations like international donors. So this one will have like a long-term sustainable impact. Thank you.
I think that makes a lot of sense. It's unfortunate that you mentioned that the global funding is not working as well as it used to, and that's deteriorating. Um, Curious for, I guess, this like global responsibility, as doctors in Africa, how do you convey the message to global stakeholders that this is urgent, that this is a need? What is your process of getting that additional funding for the health systems?
Yeah, I think funding, is not an easy thing. I've been doing, Dr. Dieudonne is now doing, to raise funding for the refugee program. But like the norm, like the usual channel for humanitarian sector, like that kind of funding is declining. So we have to move maybe to the private sectors. We have to show like the gravity of the problem, and developmental agencies. Okay, so integrating refugees and host communities together. There's a lot of funding in the developmental sector, unlike the humanitarian. So if we start mobilizing funding from the development agencies, because these development agencies normally they focus on the host communities, but because of this commitment by the member states, UN member states, called the Global Compact on Refugees, there is a kind of commitment. It may not be like a binding agreement, but this policy, is agreed by most of the countries and the government. So if we tackle on this, I think we can get more funding to the refugees, even if it's very challenging. So we have to use a different fora, to deliver these messages.
Yeah, thank you so much for kind of like explaining this process to us. Sorry, were you about to say something, Dr. Dieudonne?
Yeah, I wanted to add on what Dr. Mulugeta said. Um, I want maybe to share some experience on humanitarian funding landscape in Rwanda. Uh, of course, the funding has been declined not only since 2025, but also even before. The funding for humanitarian intervention has been decreasing since, I can say, since I joined humanitarian work. And it is now challenging. And when you look on how the fundraising effort is going on, and when you see the donor priority, I can say that it is vertical funding, because most of the funding, humanitarian funding, you see it is only specific to some intervention, not strengthening the health system for refugees. I can say like humanitarian funding, most of humanitarian funding, it's short term and it is specific for some area of health, like emergence, if I can say, or infectious disease, and it cannot strengthen the health system. So what I can say, if we get, as Dr. Mulugeta said, the funding which is not vertical, if I can say, with intention to strengthen the health system and to maintain the resilience of the health system, that funding can be channeled even to the development sector, and also to include refugee, because you know that you see, as Dr. Monogeta presented, you see that the refugee has been integrated in the national health system. So to mean whatever can strengthen the national health system can also strengthen refugee, can also include refugee. That is what I wanted to add. Thank you. Over.
Okay, thank you so much to both of you for sharing. I think that was very informative for us. And we kind of just like wanted to ask a follow-up regarding this question, because you guys mentioned that like most humanitarian funding is short term and specific towards one issue. So it's important for us to like move towards strategies that could help maintain and increase the resilience and strength of the health system. So we just wanted to ask potentially like what kinds of innovations you've seen so far that have been successful in increasing the resilience of the health system. So for example, you mentioned like community-based insurance, as well as digital health as promising solutions. So we just wanted to ask a little bit more about like the specifics of the kinds of like the types of innovations and where they're coming from in terms of improving the healthcare system in Rwanda.
Uh, yeah, thank you very much. Maybe I can say on this question, when you look, you know, community-based health insurance for Rwanda has been known globally due to its success, because it employed both top up and the bottom to the top model, and these and there is no, you can say that the access to healthcare in Rwanda in 5 years has increased to 95% of coverage due to community-based health insurance. So this, I can say that for the people of our nation, for the people of Rwanda who have community-based insurance, of course, they don't have this burden of having access to healthcare like refugees, because refugees, as Dr. Mugeta said, they rely on funding, external funding, which is unreliable. But for the community-based health insurance, it is like a success story for Rwanda, because it has alleviated the catastrophic financial spending from population. Another thing I can say on innovation for Rwanda, also, as Dr. Morgeta said, we have shifted from paper-based work to digital. And this is not only for the government health facility, but also it has included the health facility based in refugee camp, including, of course, our health centers and health posts. So this, of course, has improved the health care delivery, like decreasing the waiting time and the overall healthcare delivery. So recently, Rwanda has piloted the EU Buzima. It is it's electronic system that will be using also the artificial intelligence. And there are several parallel systems that are being piloted to see if they can, of course, increase the access to healthcare, including ThinkMD. ThinkMD, I'm not sure if you know it, but I know that it has been piloted in different countries, including US. But they are also piloting it. This is a system where even at the community level, they will be having the digital, having using local language. Even community health workers can use it to make sure that to be able to make a proper diagnosis and propose treatment, especially for the community-based services and also to the health facilities. So there is a lot of pilot which is going on, but the most, if I can say, the most very important is to make sure that the refugees are included in community health insurance to alleviate this catastrophic spending and out of pocket, of course. Yeah, thank you. That is what I can answer. If Dr. Mulugeta can add, please welcome.
Yeah, thank you, Dr. Dieudonne. Because you have recent memory and you are still working, so you are in a good position to answer this. But for me, like to make a sustainable service for refugees, integration is key. Integration is key because we don't need to have a parallel system for refugees, especially in a country like Rwanda. Like you can see, like most of the services, like chronic disease management, HIV, TB, and also even some like hepatitis, cancer screening. No, these are integrated into the national system, and we are also reporting to the national health system. So I don't want to see like a parallel system for refugees because of their identity, and they are really live close by the host community. And so if we integrate, it's not like technology, but that idea of integration into the different national system, it will make the impact more sustainable than like having like a different parallel system for the refugees. So I think we should advocate for this. We started to advocate. Some of the sectors are already integrated, so we want to have like more comprehensive integration of refugees into the national health system. That will answer, I think, most of the challenges. Thank you.
Just to quickly build off of that, so I know you said integration will make any solution a lot more sustainable. And then you also mentioned that the social determinants of health make up, I think, around like 70% of the healthcare concerns for the population. Have you seen any innovations that specifically target the social determinants of health? Or are you seeing it more related to insurance and the clinical shortage and that side?
The livelihood, maybe Dr. Dieudonne will add. Livelihood also, there is like a joint program involving both refugees and the host community, especially in the agricultural sector. So in one of the camps, both refugees and the host community, I think they were given the land to cultivate and produce like a large kind of production so that they will be self-reliant. So they are tackling not only the education and the health sector with a community-based health insurance, but they also focus on the livelihood. So it's not enough. We have to build up on this, but there is an initiative already started in regard to the livelihood, financial integration, and so on. Maybe there are also other programs started with this World Bank project. Dr. Dieudonne, do you want to add on this?
Yeah, I think it's all what you said. As you said, it's the integration. It was not only on a health care system only, but also it included the financial inclusion. As you presented, for example, for this project of World Bank, which is have intention, of course, to promote the livelihood of refugee. It will work on infrastructure, increasing the work to the refugee and also to host community. And when you look on the target, you see that it have objective to reach almost 90% of the total refugee in Rwanda. When you look on the target of this project. So this is a very good initiative. It is in the year one starting. And we hope that, of course, it will tackle social determinant of health. Another thing is, of course, other NGO are also having some parallel projects on livelihood, including some local NGO, which are promoting agriculture for refugee, especially refugee living in camp. And they are also working with UNHCR. I know that there are some other projects which are also promoting livelihood for refugee in camp. Yeah, that is what I can add. Thank you.
Okay, thank you so much for your answers to both of you. And we just kind of wanted to ask like a little bit more just about these innovations in the social determinants of health and integration and how you guys think that I guess like people such as those coming from NGOs and then also kind of like maybe doctors from the city are able to increase trust between the physicians and the refugees when they're like treating them.
Uh, I'm not sure if I got the question well.
I think something that we're curious.
Yeah,
So
could you
our
repeat it? Yeah.
yes, so for our competition, our goal is for teams to design solutions that help improve the lives of people who have been displaced. So, if you're not coming from the country itself, a lot of our participants are from the US. So for them designing these solutions, how can they be sure to have a lot of trust or invoke trust between physicians, the refugees, or displaced populations, the other stakeholders that you mentioned, especially when the cultural norms are very different between the US and Rwanda, for example, or even having like refugee generated content in any app or software that they're generating. Um, what is your opinion on creating trust? Have you seen like successful co-designing or where like the innovators will work with refugees on site? Yeah, curious about the trust angle generally in innovation. And does
Uh,
that make a little bit more sense?
yeah, I think it makes sense now. Um, yeah, of course, for every project uh, to be successful, we need, of course, to design with refugees. It means in order uh, to get the trust, we need to design the project with them, to implement with them, to evaluate the project with them. Yeah, this is the way, if I can say, the good strategy to design project. So if maybe, of course, it's hard to design a project and come and implement in area where the people you are giving the services, they didn't even know the origin, they didn't participate. So I think yes, there should be a way of working with community to design the project instead of coming with solution without the participation. That is what I can say. If Dr. Mulugeta have another alternative, please welcome.
Yeah, I think, yeah, this is also the challenge normally we face when we are implementing like newer projects, even ourselves in the camp. So normally, if you just impose something on the refugees, maybe after months or maybe a year, this project usually fails. Even so many livelihood projects we started, okay? We just give them the seed fund or capital, okay? And maybe that refugee is not interested, to do that livelihood. Even you can start maybe a kind of sanitation facility which doesn't match, the culture of the refugees. So people, they tend, to use maybe the field, on for the sanitation. So always we have to involve, that's what we normally do, involve the refugee community, different parts of the community. We have what you call AGDM, like age, gender, and diversity. You can consult the different age groups, okay, and the different gender, and also the different social classes. So involve them from the beginning, okay? Then during the implementation, that will be much easier. So the same will happen to any kind of innovation. So as Dr. Dieudonne said, it's better to start, maybe that's such kind of newer design in the context of for refugees. Even refugees maybe in Rwanda are different from maybe other countries like developed countries. So it's better to contextualize, okay, the innovation for the refugees. So we cannot generalize it to all. Yeah, thank you.
Thank you so much for your responses, guys. That makes a lot of sense. And kind of like emphasizing that importance of including the local population and those who will receive the innovation is something that is going to be very beneficial, like moving towards the future. So just like another kind of like similar thing that we wanted to touch upon was maybe like different challenges and innovations towards a specific group of people, and that would be like the maternal and newborn health, like the mothers and the children. Since you said that that was like around roughly like 75% of the population, we just wanted to see like what kinds of unique problems does this population face, and what types of strategies have been developed in order to target these issues. Thank you.
I think in like developing countries, including refugees, when it comes to the maternal health, the main issue is like postpartum hemorrhage. After the giving birth, women suffer from this bleeding, torrential bleeding called postpartum bleeding. So this is like in regard to the maternal health, this is the main challenge. So if there are some, there is like the modern treatment. If you can have that treatment effectively, you can save the life of the mother. But still, the maternal days is high, especially in the low middle income countries. So why is that? So there should be kind of, I don't know, I may not like devise like innovative ways, but there should be some kind of easier way of controlling the bleeding. Even the mother delivers sometimes at home. So all women, luckily in refugee camps, like most of the deliveries happen in the health, like institutes or in health facilities. But in other areas, in rural areas, where there is a distance between the health facility and home, these deliveries happen at home. So there should be kind of easier way of management of this postpartum hemorrhage. I think there are some like innovations tried, even with the University of Global Health Equity. There is some innovative sector that are trying, a new and cheaper, acceptable, okay, which is feasible way of controlling the bleeding than the modern treatment, which can be available at home. So this kind of, innovation is very important because maternal death, it's not acceptable. Yeah.
Yeah, can I add?
Yeah, go ahead.
Yeah, please,
Yeah, thank
please.
you very much. Yeah, I think you asked on the challenges on maternal and newborn health care in refugee camps in Rwanda, and also the solutions. As we said in the presentation, of course, when you look on, the most challenge is access. When you compare the national health system with refugee, although it is integrated, but especially let's take for example antenatal care. When you look on antenatal care visits compared to national or host community, you see there is a difference, mostly due to cultural norms difference, and what Dr. Mulugeta said is so-called social determinant of health, the different. Uh, when you look on postnatal care, the follow-up, it is very different from the community context to national context. So I think, of course, we have tried our best to make sure that we adopt the system of national system, having community health worker in a refugee camp, uh, to make sure that they are doing community-based interventions, like following up the pregnant women for antenatal care, for food supplement, for postnatal care. But of course, uh, coming back to social determinant of health, you found that it affects everything. Uh, if, of course, we find an innovative solution which can facilitate to do a better follow-up at community level, including maybe digital. Of course, it will require to have some knowledge. You understand that, of course, it will need to improve the education of community health workers. That will be awesome. And also, as Dr. Mulugeta said, uh, after tackling the social determinant of health, like increasing livelihood activities, which will, of course, improve the economic status of refugee. These, of course, will for sure increase the access to healthcare, especially for maternal and child newborn health. Yeah, that is what I can add. Thank you.
That's super interesting. I think from what I've been hearing, it seems like access and funding are some of the two biggest problems with healthcare for refugees right now. And also the importance of co-designing with the refugees and the importance of integration. As we wrap up, I wanted to ask you both one last question. If you had a magic wand and you could change anything right now, or come up with like a magic solution right now, what would you have that be to improve the lives of the refugees? And similarly, for participants who might be interested in innovating in the space, maybe specifically for Rwanda, what would you want their last key takeaway to be?
Yeah, I don't know if there is a magic bullet eh, or a panacea solution, Yeah, it's because the problem is, very broad, very wide. So I think the solution also should build up on what we started, what's working well. So I don't think there is a single solution, that can, resolve all these, problems. As you know, social determinants of health, poverty. How can you, like, elevate the poverty level of refugees? And the education, most of the adults, maybe they are not educated. So what you are going to do with it? It's already the damage done. So maybe the solution is like, maybe, when newborns are, like when you receive the newborn, you start, the care, maybe even before the baby is born from the pregnant woman, and build up. It may take like, I don't know, some years, to resolve, this big problem. So in my thinking, I think there is no magic bullet for this solution, but let's work on what's is working well for the moment and build slowly and gradually. Maybe Dr. Dieudonne is young, maybe he has another thinking. So over to you, Dr. Dieudonne.
Yeah, thank you. I don't also have a magic solution.
Ah,
And when you look on this, the issue is common in low and middle income countries, not only refugee. Even when you look on those countries in general, access to healthcare is a challenge. So I cannot say that I can propose a single solution that will reverse the issue of access to healthcare. But of course, as we have discussed, we have already identified the issue, including funding, including refugee integration in health system. Of course, this can resolve the issue progressively, not immediately, if I can say, but slowly by slowly. I think this can change things, and uh, maybe in 5 years, in 10 years, in 20 years, yeah, I think can be looking in another image. Yeah, that is what I can say. Thank you.
Well, thank you for that note. I think that that is at least a little bit hopeful that although there's no magic solution, at least we know the problems and we can work on innovating for them. So thank you both so much for your time. Again, for all the people who are watching, our applications close September 22nd, so please apply. This is an awesome competition to innovate in global health, and we will see you for our next Open Learning Series event.